Merci, Dr. Samir, ربي يخليك. Many thanks, Dr. Hisham, for such a valuable, interesting presentation. It's a great pleasure to me to introduce my sincere, dear friends, Professor Dr. Nesrine El-Refai. She's an eminent professor of anesthesia, surgical intensive care, and pain management at Cairo University. She's a member in the World Federation of Societies of Anesthesiologists. She is also a great expert in difficult intubation and made a lot of workshops regarding difficult airway management. And she was former member in the Obesteric Anesthesia Committee in the World Federation of Societies of Anesthesiologists. She will talk to us about a very interesting, important topic related to anesthesia management for morbidly obese patients. Please, Dr. Nesrine, go on.
Thank you, Dr. Khalda. I'd like to thank everybody. I'm really honored to share my lecture in this great course, valuable course, and hope you enjoy my lecture. Is my voice clear?
Yes, everything is fine, thank you.
We are talking about perioperative management of obese patients. Actually, this topic is very important, and it's not a lecture, it's specialty. So we can talk about obesity in several lectures and courses. In this lecture, I'll try to highlight specific points regarding management of obesity. First, definition, preoperative assessment, including airway, respiratory, cardiovascular assessment, drug dosing, regional anesthesia problems, and general anesthesia. Obesity is increasingly common in surgical population, with over than 60% of adults in UK classified as either overweight or obese. And obese patients are challenging patients for anesthetists, as they have increased incidence of comorbidities as hypertension, diabetes, cardiac disease, obstructive sleep apnea. What is the definition of obesity? The word obesity is derived from the Latin word obesus, which means person who is flattened by eating. The body usually express obesity, according to WHO, as a body mass index, which means which is calculated by division of the weight in kilogram on the height, square of the height in meters. So, for example, if someone has a weight of 100 kilograms and the height 1.6 meter, so the body mass index is calculated by 100 divided on 1.6 square. Accordingly, you can classify obesity into patient with body mass index less than 20 kilogram per square meter. This is underweight. 20 to 25 kilogram per square meter is normal. 26 to 29 overweight. More than 30 up to 39 is considered obese. And then the WHO will further classify obesity into class 1, 2, and 3, and I'll show you in the coming in the lecture. But sometimes they call patient more than 40 kilograms morbidly obese, more than 50 super obese, more than 60 super obese, more than 70 hyper morbidly obese or mega morbidly obese. And this chart shows the risk associated diseases according to body mass index and the weight and the waist size, as we will see. Here is the classification, because sometimes you have to know it, because in literature they may express obesity into class 1 and class 2. So class 1 is the body mass index from 30 to 34.9, class 2 from 35 to 39.9, class 3, which is severe, massive obesity more than 40. Commonly we use the BMI, but there's also another important classification. It's the distribution of adipose tissue rather than the body mass index. Here we have two types of obesity. Android on the left, this is android or central or apple-shaped obesity or truncal obesity. They all express the same shape. Or gynecoid or pear-shaped obesity when the adipose tissue is in the lower part of the body. The importance of this classification is that central obesity is associated with many problems as difficult airway and ventilation, high risk of cardiovascular disease and thrombosis and metabolic syndrome, while the peripheral or pear-shaped obesity is, has less comorbidity and lower risk. Let's concentrate on the 4 terms used to describe the patient's weight. We have to know these terms because we will use them when talking about drug dose and how to calculate it. Some drugs are calculated according to actual or total body weight, or ideal body weight, or lean body weight. You will hear all these expressions when we talk about drug doses. Total body weight is the actual weight of the patient. Ideal body weight is the dream of all of us, especially females. It's the normal ideal weight of a person according to the height and sex. Here the ideal body weight equals, according to this formula, it's very easy, and even lay person, they know it. It's the height in centimeter minus 100 in male or 105 in females. So if the man has a height of 160, then his ideal body weight is 160 minus 100, which means 60 kilograms. The lean body weight is the patient weight excluding fat, and it's there's very a lot of formulas that are used to calculate the lean body weight, and they are all complex, and we don't have to know all of them. But what's important to know is that the lean body weight is approximately 75% of the actual weight, as some dietitians say. And regarding anesthesia and drug dosing, we have to know that regardless of the total body weight, the lean body weight rarely exceeds 100 kilograms in men and 70 kilograms in women. So even if you have a patient who has a body weight of 250 kilograms, you calculate certain drugs according to lean body weight, which is maximum 100 kilogram for male. And the last formula is called adjusted body weight, which means the ideal body weight plus 40% of the excess. The excess means the total body weight minus the ideal body weight. Then we come to preoperative assessment. This table shows the obesity-related medical condition according to the organ system. The respiratory system, we have a lot of problems: asthma, restrictive lung disease, sometimes obstructive sleep apnea, obesity, hyperventilation syndrome, and so on. Cardiovascular disease, it's common to have hypertension, cardiomyopathy, congestive heart failure, coronary artery disease, thrombosis, endocrine or metabolic. There is type 2 diabetes, Cushing syndrome, hypothyroidism, hyperlipidemia. The GIT problems include hiatus hernia, gallbladder problems, and regurg, and high risk of regurg and aspiration. Musculoskeletal disorders are also common, malignancy, and psychiatric disorders. Obesity-related disease, according to its incidence, type 2 diabetes is present in one of the recent studies. It was a large survey, and they found that type 2 diabetes occurs in almost 20% of the obese patients. Hypertension occurs in 30%, depression in 12%, musculoskeletal pain in 24%, sleep apnea in about 18%, and GERD or the regurg in 17%. Here is a very long list of routine preoperative investigations that we do for obese patients. What are the anesthetic considerations for the obese patients? The airway, we will talk mainly about obstructive sleep apnea and potentially difficult airway. Respiratory problems include obesity, hypoventilation syndrome, pulmonary hypertension, and restrictive lung disease. That's why we ask for respirometer and respiratory functions for the morbidly obese patient before anesthesia. The cardiac problems include hypertension, left ventricular hypertrophy, coronary artery disease, and endocrine disorder, as we said. And very important consideration for anesthesia is altered pharmacology. Obesity itself changes the pharmacodynamics and kinetics of many drugs and anesthetic drugs. Technical difficulty that we have to deal with is vascular access, monitoring the blood pressure, which is simple, but it's difficult in obese patients. Difficult regional anesthesia. And this table is used for obesity surgery mortality risk stratification score according to risk factor and risk of mortality. And I think you can read it here, and there is no need to waste our time. Let's define our goals. Our anesthetic goals is to manage the airway safely, avoiding hypoxemia and aspiration, evaluate the impact of obesity on the patient, establish whether regional technique can be used in this patient and this type of surgery, minimize the perioperative complications, especially post-operative airway, thrombotic complications, and nerve injury. Preoperative assessment of obese patient start with airway. Being instructor in the airway management, I'm concerned with airway, and I teach the courses of difficult airway, and I'm a member in a Difficult Airway Society of UK and Society of Airway Management in USA. But usually I stick to the DASE, the Difficult Airway Society of UK algorithm, as I find them it's more comfortable to use and very simple and straightforward. Anyway, obesity is associated with 30% chance of difficult intubation, which is very high percentage. Predictors of difficult laryngoscopy, by the way, are the same as for non-obese. So when you assess the airway of the obese patient, you use the same score that you use for other patients. If you are familiar with Ganzuri score, for example, which is a very good score, and we knew this score from Dr. Ganzuri, God bless his soul, and it's the only score that combine the scoring system with the management. But you are not obliged to use certain score but it's better to use a score that assess different issues in the patients, as Ganzuri score, Lemon score, Wilson score, and Makbul score. Use all these scores in obese patients, and to be more accurate and more valid, you have to detect the neck circumflex. It's said in literature that when neck circumflex more than 60 centimeter detected at the center of the neck or at the site of Adam's apple, there is 35% probability of difficult laryngoscopy. A very important part, and actually it's in the definition of difficult airway, not only difficult intubation, it is the difficult ventilation, the bag mask ventilation. The bag mask ventilation is also known to be more difficult in obese patients, and that's more dangerous than the difficult intubation. And we have what's called safe apnea period. It's the time between full muscle paralysis and apnea until the oxyhemoglobin saturation decreases to dangerous levels. In obese patients, it's detected to be 2 to 3 minutes versus 8 minutes, for example, in normal population. That makes our time of management of intubation is very critical. Obstructive sleep apnea can be evaluated by what's called stop-bang score. Here is the management of unanticipated difficult airway according to the Difficult Airway Society. We can talk about, I have a lecture about safe airway management describing in this algorithm. We can take this lecture another time. Obstructive sleep apnea means the airway is obstructed during sleep due to lax muscles of the pharynx, tongue, and soft tissues. Here is the normal airway, as we see, and in obstructive sleep apnea, the airway is blocked. Prevalence of obstructive sleep apnea is very high in the obese population. The stop-bang score is the score of 4, provides a better balance of sensitivity and specificity in the obese population. And according to current opinion of anesthesiologists, the score of 4 provides better balance of, if the patient takes score 4, it has a better balance between sensitivity and specificity of obstructive sleep apnea in this patient. In morbidly obese patient, stop-bang score of 4 has 90% sensitivity for detecting severe obstructive sleep apnea. And usually obstructive sleep apnea is the complaint of the wife, as we see. What we mean by stop-bang? S means snoring. T, tiredness, the patient is tired and feels fatigued and sleepy during the morning and daytime. O, observed, we ask the patient, did anyone observe you during sleeping and he saw that you stopped breathing, or you had choking or apnea or gasping. P, for blood pressure, do you have a high blood pressure? B, for the BMI, BMI more than 35 kilograms per square meter takes 1 point in this score. Age more than 50. N is neck circumference more than 43 for males and 41 in females. G, gender, it's more common in male. So the stop-bang screening questionnaire for obstructive sleep apnea will give 1 point for each positive feature, and if we have a score of 5, it's significant of severe obstructive sleep apnea. Actually, recently, I found the literature talking about the validity of stop bank questionnaire, and researchers started to modify the stop bank questionnaire. So after detecting the score, they give another classification. For example, they say score of 0, 1, or 2 is low risk obstructive sleep apnea, and 3 or 4 means intermediate, and the high score is from 5 to 8. Or they detect the stop score if it is more than 2 and plus male gender, it means high risk obstructive sleep apnea. It's something complicated. What our goal is to find a very simple and score that we can rehearse and easy to remember and is valid to detect obstructive sleep apnea. And here I got you this surprise. I found a very new, recently discovered score called GOAL. It was published in the Nature and Science of Sleep in June 2020. It's called GOAL because they assess gender. This score or questionnaire is newly validated for obstructive sleep apnea. It has 4 items with only yes or no answer. So G for gender, if he is a male, he takes 1. O, obesity, obese patient, more than the body mass index more than 30, takes 1 score. A, age more than 50, takes 1 score point. L, loud snoring, takes 1 point. So the final score ranges between 0 and 4 points. And score more than 2 means a high risk for obstructive sleep apnea. And here is the this table is about the questionnaire. Then how to manage, if I find a patient with obstructive sleep apnea, how to manage or this patient and decrease the complications during anesthesia. It's proved that the best treatment for obstructive sleep apnea is CPAP. And now we have 2 types, either this conventional CPAP mask or the transnasal CPAP. What the importance of obstructive sleep apnea? Moderate to severe obstructive sleep apnea increases mortality, and according to American Association of Clinical Endocrinologists, Obesity Society, American Society of Metabolism and Bariatric Surgery, they all advocate preoperative screening and start preoperative CPAP in the high-risk patients. And they found that preoperative CPAP decreased hypoxemia, pulmonary vasoconstriction, and in the perioperative period, it also decreases hospital length of stay and postoperative complications. And also postoperative CPAP is important to reduce the risk of pulmonary restrictive disease and acute respiratory distress syndrome. And here is one of our colleagues trying to manage intubation in obese patient. What is the influence of morbid obesity on intubation and difficult mask ventilation? Strange enough, I found this article in the Journal of Anesthesia 2019. They concluded that morbidly obese patients do not have higher incidence of difficult intubation compared to non-morbidly obese. What a surprise. But they have a higher incidence of difficult mask ventilation, and this is very critical. Other factors that are predictive of both difficult mask ventilation and difficult intubation include age more than 46, male sex, Malampeti 3 and 4. Then we have to optimize the airway during anesthesia. Of course, if you have an obese patient with obstructive sleep apnea, you will be ready with all the different airway kit with different blades, fiber optic, the flexible fiber optic, video assisted laryngoscopy, different blades as McCoy, different tubes, and the supraglottic devices is they are plan B for difficult intubation and ventilation. So they are life-saving. Airway optimization, according to the Journal of Clinical Feature 2018, they found that video-assisted laryngoscopy, it's unclear whether it's better than the conventional direct laryngoscopy. It's the research is debatable. But you can try to increase the safe apnea period by pre-oxygenation. Now we'll talk about different methods of pre-oxygenation that give the patient and give the anesthetist more time to manage the airway before the patient develop severe apnea and desaturation. And positioning of the patient is very important. The best position for obese patient is called rampant position. It's the head elevated position with the OR table in the reverse Trendelenburg. Next, you have to keep the airway open during apneic oxygenation with different maneuvers, head elevation, jaw thrust, nasal or oral airway, whatever convenient. Different airway kit, as we said. And then, if you are going to manage the airway in obese patient, mostly for general anesthesia, you have two options. Either awake fiber optic, which is the safest for difficult intubation, because as Dr. Ganzouri says, and as most of the literature describe, it's very difficult to kill an awake patient. So the awake fiber optic is a very good choice. If you have to put the patient to sleep, then it's better to use the rapid sequence induction and to intubate as rapid as possible to prevent, secure the airway and prevent aspiration. If you have CPAP, it's, as we said, it gives preoperative CPAP. If you have a difficult direct laryngoscopy, don't waste your time and manage according to Difficult Airway Society guidelines. Here is the rampant position. Decrease it's we put the head up and put pillows behind the patient head and the upper trunk. It reduces the risk of difficult laryngoscopy, improves ventilation and pre-oxygenation. How to know that you have applied the good ramping position? When you have the tragus of the ear in the same line with the patient's sternum. Now, how to optimize and increase the safe apnea period? There's different pre-oxygenation techniques. One is called THRIV, which means transnasal humidified rapid insufflation ventilator exchange. Very easy. And if you use this technique, use 30 liters per minute of humidified oxygen. Or simply use the face mask with 100% oxygen, 6 liters per minute for 3 minutes. Or buccal oxygenation, it is a modified ray tube of size 3.5 millimeter placed inside the patient cheek, plus adding CPAP of 15 centimeter water. Here is the THRIV technique. you should have this device. And here is the buccal oxygenation with the small ray tube inside the patient cheek. Now we finished the airway and we'll come to respiratory complications. Respiratory assessment include assessment of obesity, hypoventilation syndrome, chronic daytime hypoventilation and hypoxemia, permanent hypercapnia more than 45 millimeter mercury, advanced obesity more than 40, Pecquekian syndrome. It's Pecquekian. It was, I think, related to Charles Dickens. It's one of the cartoon of Charles Dickens. He was talking about an obese boy who is often sleepy and feel tired by and cannot sleep in the morning and cannot sleep well by night. These patients have severe obstructive sleep apnea and hypoventilation syndrome with core pulmonale. Obesity and hypoventilation syndrome or COPD, they lead to chronic hypoxemia, pulmonary hypertension, right ventricular hypertrophy, and end by right ventricular failure. And there it has a high perioperative morbidity and mortality rate. Here is the Pecquekian patient. He has decreased central respiratory drive. The airway is potentially difficult with obstructive sleep apnea, usually coronary artery disease, congestive heart failure, difficult vascular access and difficult positioning, restrictive chest physiology, pulmonary hypertension, and hypoxemia. That's why when we have an obese or morbidly obese patient, we ask for important investigation, which is respirometer or pulmonary function tests. So I just want to remind you with this physiology, what we mean by inspiratory capacity, expiratory reserve volume, residual volume, functional residual capacity. Here is the functional residual capacity. And here is the flow volume loops. And actually, as anesthetist and consultant, you have to know the flow volume loops and how they look like in different population. Here is the normal patient. That's this is the expiration, and here is the inspiration. With obstructive disease or COPD or asthmatic patient, we'll find this loop. The expiration is flattened, looks like this. But in restrictive lung disease, the patient is huge and obese, but this adipose tissue decrease the lung function, and he has restrictive lung disease, so the flow volume loop will look smaller than the normal and shifts to the right. All lung volumes are decreased. Here you can see the normal patient, the early small airway obstruction, bronchitis or bronchial asthma, and chronic obstructive disease, more flattening of expiration. Fixed large airway obstruction looks like that. Variable extrathoracic large airway obstruction, extrathoracic, not intrathoracic, and the restrictive lung disease. The following features may indicate the presence of significant underlying respiratory disease in the obese patient. If you have arterial saturation less than 95% on air, forced vital capacity less than 3 liters, or forced expiratory volume in the first second less than 1.5 liter, or respiratory wheezes at rest, serum bicarb concentration more than 27 millimole per liter. The perioperative respiratory changes, which occur during anesthesia, according to the BGA 2020, the oxygenation is managed by reduction in the muscular tone during induction of anesthesia due to loss of the chest wall and diaphragm, loss of the tone in the chest wall and diaphragm with general anesthesia induction and muscle relaxation, of course. The net effect is decrease in the expiratory reserve volume and functional residual capacity by more than 50%, leading to post-operative atelectasis. Atelectasis during general anesthesia increase with the age up to 50, and guess what? It decreased beyond that. These researchers, they found that atelectasis increased with BMI in normal and overweight patient, but showed no further increase in obese patient more than 30 kilogram per square meter. It's related to the body mass index, but it's against our beliefs. We used to believe that the more obesity of the patient means more instance of atelectasis, but this study suggested that atelectasis may increase during general anesthesia with age up to 50 years. Then it doesn't increase furthermore with advanced age, and doesn't increase with more obesity, more than 30 kilogram per square meter. Then how to ventilate? The important question is how to ventilate this patient intraoperative. Actually, this question is not answered in literature till now. There is no strict guidelines as how to ventilate these patients. What strategies or mode of ventilation can you use for the obese patient? However, there is several recommendations in literature. As we all know, it's recommended to use PEEP, 10 centimeter water PEEP in you use it in the ventilator, in the anesthesia machine, intraoperative, for obese patient and during bariatric surgery. And other literature advise using small tidal volumes from 6 to 12 milliliter per kg of ideal body weight. Here comes the first expression, ideal body weight. So we don't give the tidal volume according to the actual body weight. If I have a patient of 200 kilograms, I don't give a tidal volume of 6 multiplied by 200. I give the tidal volume according to ideal body weight. And it's suggested that we use FiO2 less than 0.8 to maintain physiologic oxygenation. So don't use 100% oxygen. The respiratory rate adjusted to maintain normal apnea. And some authors reported using high tidal volume and high PEEP to maintain the functional residual capacity. Now we come to cardiovascular assessment. These patients have high risk of essential hypertension, left ventricular hypertrophy, pulmonary hypertension, arrhythmias. It's common, especially in patients with obstructive sleep apnea. It's caused by hypoxia and congestive heart failure. The workup, what investigation do we ask for? We ask for everything. Chest X-ray, 12-lead ECG, echo, cardiograph, spirometry, and ABG. Metabolic syndrome should be assessed. Cardiopulmonary exercise test may predict those at high risk of post-operative complication and increased length of stay in the hospital. And now they have maneuvers for the obese patient to detect their cardiac function with exercise. So they don't have to use these bikes and these ordinary devices. The cardiologists in some centers, they have other devices that the morbidly obese patient can use. Now we come to a very important problem. It's detecting the blood pressure, simply detecting the blood pressure of the obese patient. It's actually challenging, and the American Heart Association recommend this arm circumflex and cuff size according to take the blood pressure correctly according to the patient arm circumflex. So it tells you when to use the small cuff or the adult cuff or large adult or adult thigh. But simply, at least keep the cup width 20% more than the upper arm diameter, or 40% of the circumflex of and 2/3 of the arm length. 40% of the circumflex and 2/3 of the arm length. Intraoperative hemodynamic monitoring start by blood pressure. If it's not feasible and you don't have a very large cuff and you can't detect the cuff in the arm, it's okay to detect it in the, around the ankle or the wrist or forearm. And the blood pressure cuffs intraoperative should encircle 75% of the arm. Or use invasive arterial pressure, and sometimes in high-risk patients you may need pulmonary catheter monitoring, especially in the super obese patient more than 60 BMI, or patient with severe cardiopulmonary disease. Intraoperative transesophageal echo have been used in some patients, but we can't say it's mandatory for every operation for every obese patient. Of course, it has certain indications. The American College of Cardiologists and American Heart Association guidelines recommend post-operative cardiac monitor in patients with coronary artery disease, as it's not uncommon to for the obese patient to develop thrombosis, angina, and maybe infarction post-operative. And these current topics in anesthesiology, this book in 2017 talks about 6 risk factors to predict the cardiovascular morbidity. High risk surgery, if the obese patient is undergoing emergent or major thoracic or abdominal vascular surgery, history of coronary artery disease, history of congestive heart failure, history of cerebrovascular disease as stroke, preoperative insulin treatment, preoperative plasma creatinine level more than 2 milligrams per deciliter. What about the GIT? These patients have high risk for aspiration of gastric content. So all precautions against aspiration should be done, as giving H2 antagonist, antacids, prokinetics, proton pump inhibitors, using rapid sequence induction with cricoid pressure or Selleck maneuver, and rapid tracheal intubation. And by the way, it's recommended that every obese patient, whatever the operation is going through, should be intubated by endotracheal tube. Don't use, the research says, don't use the supraglottic devices in morbidly obese patients except in very strict and very cautious conditions. When you are 100% sure that you are securing the airway and it's, for example, it's very minor procedure, and you are using the second generation of supraglottic devices like Procil or any supraglottic device that you can introduce the nasogastric tube and you are sure the stomach is empty. And these patients has high risk of diabetes, especially type 2 diabetes, So it's recommended that the preoperative glycemic control detected by hemoglobin A1C is around 7, or fasting blood sugar less than 110 milligram per deciliter, or 2-hour postprandial less than 140 milligram per deciliter. But recently, a less tight control can be applied to patients with extensive comorbidity. The recent researchers found that on the long run, the patient, the old patient with diabetes or patient with other comorbidities is angina and cerebrovascular disorders, they have the life, they live more and they live better when we have less tight control. So don't keep them the fasting blood sugar at 80 or 90, because there is high rate of hypoglycemia, which is very dangerous. And now this recommendation can be applied to the patients in OR. So you can use less tight control. It's okay if you have a patient with fasting blood sugar of more than 110 up to 150, no problem. And before surgery, remember that oral hypoglycemia should be stopped, and we shift to insulin according to sliding scale. Some literature say that intensive insulin therapy, keeping the blood glucose around 110 milligram per deciliter in the perioperative period, reduces hospital death and length of stay in the hospital. Now we come to the problem of drug dosing. Obesity has significant effect on the metabolism and pharmacokinetics of most anesthetic agent. The lean body weight, as we said, it exceeds the ideal body weight in the obese patient, but it reaches plateau. It's not more than 100 kilogram for men and 70 kilogram for women. The ideal body weight, as we said, is detected by Broca formula. And the anesthesia. Here is the anesthesia for obese patient according to Society of Obesity and Bariatric Anesthesia. It's the new guideline in UK 2020. The drugs doses are detected according to lean body weight. Propofol induction and not infusion. Thiopentol, fentanyl, morphine, non-depolarizing muscle relaxant, local anesthetic, and paracetamol. And these drugs, the propofol infusion in case of TIVA, total intravenous, the neostigmine, the sugammadex are used according to adjusted body weight, which is the ideal body weight plus 40% of the excess. Why the saxamethonium, the succinylcholine, or the low molecular weight heparin are given according to total body weight. Thromboembolism is a very important complication because obesity is a high risk factor for DVT and pulmonary embolism, which could be fatal. And thromboembolism is found to be one of the commonest post-operative complications. That's why in obese patients, it's recommended to use two methods to prevent thromboembolism: pneumatic compression plus anticoagulant. But there are no universal dosing protocol or standard type of anticoagulant or dosage duration. And that's according to the Obesity Surgery Journal 2020. The literature here described different regimens and different types of anticoagulant, different protocols, and there is no universal dosing protocol. But the important finding in this research is that they assured us that whatever the method of anticoagulation you give, you detect its efficacy with measuring the activated factor 10A. you detect the level, and it helps to define the real thromboprophylaxis status in obese patients. The clinical practice guidelines recommend that we use either unfractionated heparin or low molecular weight heparin, started within 24 hours post-operative, and then extend the duration in high-risk patients. And literature here is not universal. Some authors say if you have a very high-risk patient, you have to continue the anticoagulation for 30 or 35 days post-operative. And some literature support the weight-based dosing monitored by factor 10A level, as we said. So, if you are using the low molecular weight heparin, give it according to the body weight, 0.5 milligram per kg of the actual body weight subcutaneous, and don't use the doses that the standard doses that we use, therapeutic dose and prophylactic dose, 60 international unit or 80. Be strict to the actual body weight, and our target factor is factor 10A level between 0.2 to 0.4 international unit per milliliter. And recently, the literature approved that the new direct oral anticoagulant can be used in morbidly obese patients. They are safe and effective alternative to warfarin. What about obese pregnant? That's very special lecture that I have this lecture, and it's updated, and of course you can't cover the whole problems here, but the obese pregnant patient has many hazards and many complications, and should be treated cautiously. The choice of anesthesia is also very crucial. The obese patient who is pregnant has increased risk of miscarriage, gestational diabetes, preeclampsia, thromboembolism, prolonged labor, and most of them they need cesarean section, and they have high risk postpartum hemorrhage and mortality. What are the technical problems with obesity? We have to be ready with the equipment needed for obese patient, such as suitable trolley and OR table. Sometimes we put two tables together if the patient is super obese. Sufficient personnel to help in monitoring and carrying the patient. The monitors you need is large blood pressure cuff, monitor depth of anesthesia. Why? Because we found that there is high risk of awareness in these patients. And neuromuscular monitoring is mandatory. Equipment for ramping, to put the patient in ramping position. Step for the anesthetist, because as we saw in the caricature, the patient is huge, and the anesthetist may need to be in on a step, so the patient will be at the level of the sternum for easy intubation. Difficult airway equipment, ventilators that can give PEEP and different pressure modes. If you are going to use regional anesthesia, you will need long spinal and long epidural, the vascular needles. Ultrasound is very helpful because you can use it to put intravenous cannula. You can use it to direct during regional anesthesia, and compression devices for thrombosis. What are the choices for anesthesia? Regional anesthesia is safe, yes, but it's technically difficult. when you have a huge patient and you don't have landmarks, you don't know where is the iliac crest and where is the midline. This picture shows one of the tricks that our colleagues in USA have taught us. They have a high incidence of obesity exceeding 60%. So it's not uncommon to have a morbidly obese or super obese patient. So sometimes they ask the patient to identify her own midline on the vertebral column, and they put a line here, and so they know where to put the spina and epidural. And sometimes they use the C7, identify C7, and go with a line directly downwards. Of course, if you have an ultrasound and you are professional and know how to use it, you can use it to give epidural anesthesia, but don't try to give it for the first time and use ultrasound and you are not expert. The regional anesthesia has pros and cons. The pros are, of course, avoiding difficult airway, post-operative complications, and the block may be performed under ultrasound. The cons is that distribution of local anesthetic is hard to estimate, and there is difficult detection of the landmarks. There is high failure rate. It's by literature, there is a high failure rate and a high rate of complication as a wet tap during epidural, for example. Then we come to general anesthesia, rapid sequence general anesthesia. The sedative pre-medication is better to be avoided, or it should be avoided, especially in patients with obstructive sleep apnea. It's totally unsafe to put the patient into sleep while you are outside the OR. You may lose the airway and you lose the patient. And you need this patient to be awake, because it's recommended that you encourage the patient to walk in and lie on the OR table. That's much more safer than having a huge patient and the personnel trying to transfer him. It's not uncommon to drop the patient or have fracture. Aspiration prophylaxis, don't forget it. Induction in the ramped position after putting IV line, which could be difficult and can be guided by ultrasound, and in some cases it's reported that they had to put CVP to perform induction. IV induction with mouth relaxation and intubation, as we said, the supraglottic devices and spontaneous ventilation should be used with extreme caution. CPAP is used during pre-oxygenation, as we said. For difficult airway, either use awake fiber optic or rapid sequence induction using succinyl 1 milligram per kg actual body weight, or rocuronium 1.2 milligram per kg of ideal body weight. So the succinylcholine, due to the volume distribution, we have to give it according to the actual body weight, while the rocuronium, it's recommended to be given according to the ideal body weight. Drug dose, some literature say that, actually this is the guideline of UK. They say, as a rough guide, for most of the drug, including induction agent, opioid, and non-depolarizing muscle relaxant, use the ideal body weight plus 20%. This is very rough guide, just to remember. Induction by propofol, as we said, according to the total body weight or actual body weight. Opioid, the use of opioid is very risky in obstructive sleep apnea, up to that some authors do not recommend using any narcotics in patients with obstructive sleep apnea or central sleep apnea. or upper airway obstruction, as it may lead to severe obstruction hypoxemia. Anesthetic agent use anesthetic agent with rapid offset as desflurane and remifentanil, which facilitate a rapid emergence and extubation. PEEP is used to reduce alveolar collapse and atelectasis. Analgesia, it's advised to use multimodal analgesia to reduce the perioperative opioid requirement, such as IV paracetamol, local anesthetic, non-steroidals. During recovery, the neuromuscular blockade must be completely reversed with glycopyrrolate neostigmine given according to actual body weight, or Sugammadex, and this Sugammadex has a very important role. There's many studies that assess Sugammadex in obese patients, especially in bariatric patients, and we recommend its use. And it's found that Sugammadex can be used for moderate neuromuscular blockade, which means, by definition, 2 or more twitches of the crinophore. Here we can use a dose of 2 milligrams per kg total body weight. So the Sugammadex is given according to the total body weight. And other authors say that you can use a lower dose. They tried using 4 milligrams per kg of the ideal body weight, which is much less than the total body weight. And they used it for a patient in a deep neuromuscular blockade, and it was found to be suitable to reverse the patient completely. So the research here is still conflicting. Extubation should be done with the patient fully awake in the sitting position on bed before being transferred to the recovery room. If you have a patient with obstructive sleep apnea, take care, insert nasopharyngeal airway before extubation. CPAP equipment should be immediately available at extubation, and it's common practice now that when we have a patient with obstructive sleep apnea, usually these patients have their own CPAP at home, and so we can ask them to get the CPAP and use it pre-operative and post-operative. The patient will be more familiar with it. Post-operative care, take care of preventing respiratory dysfunction, hypothermia, hemodynamic instability, thromboembolism, nausea, vomiting, and pain. Monitoring should be continued in the recovery room with the patient in the sitting position. Oxygen support until the saturation return to the pre-operative level. The take-home message: obese patients present a challenge for the anesthetist. Obesity is associated with type 2 diabetes, hypertension, depression, obstructive sleep apnea, and reflux. Careful pre-operative assessment is mandatory. Decision of regional versus general is crucial, and prepare all the equipment and monitoring. Use multimodal post-operative analgesia, and remember to prevent the post-operative complications. Thank you.
Dr. Nesrine.
I finished.
Many thanks, Dr. Nesrine, for such a valuable, interesting presentation.
I know it's a little bit long, but I couldn't summarize it.
It is a very difficult subject. Yeah, you have to make it easy.
Yeah.
Many thanks.
Last minute, I hoped that Dr. Saad says
Not at all. We
about
cannot.
Obesity in pregnancy, or talk about airway obesity.
No other one can give this lecture, Prof. You know, that's very interesting. Thank you very much.
Thank you.
There is some questions. We'll start with Dr. Ibrahim asking about what is the safest technique of induction of anesthesia for the obese patient.
The awake fiber optic. The awake fiber optic is the technique that is used to induce anesthesia for the obese patient. It is a very difficult subject. Yeah, you have to make it easy. Many thanks. The awake
induction of anesthesia يعني let's say it is an inhalation induction awake fiber optic يعني no induction. Let's start with fiber optic.
That's the most safe.
Okay. Dr. Saad asked about the rapid sequence induction. Would you see better to use the saxamethonium or rocronium?
Actually, both are safe. But for saxamethonium, commonly we forget to give it according to the actual body weight. So we give 1 to 2 milligrams per kg. If you have a patient of 200 kilograms, you will need.
We underestimate the dose of the saxamethonium.
So the patient is not fully relaxed, and this will make things difficult for you during intubation. So I prefer using Ismuron because it relaxes the patient, and in the appropriate dose, it gives full relaxation within 60 seconds, similar to succinylcholine. If we have, of course, if we have Sugammadex, so in case it's extremely difficult intubation, and I can put a supraglottic device and awake the patient and give the reversal by Sugammadex.
Dr. Ahmed asked about the rampant position. Can be obtained with just raising the back of the OR table without adding any bellows? Can we give the position by that act?
No, it's written in the literature, and it's described that it's not enough to get the table in the semi-sitting position or 45 degrees. They tried all these positions. You have to put pillows behind the patient head, neck, and the upper trunk.
Thank you very much. There is another question from Dr. Ahmed Kandil about the fluids management maintenance. Can it be given on the ideal lean or the actual body weight? How can we adjust the maintenance?
No, it's given according to the ideal body weight, and it's recommended that we don't give excess fluids, as we may end by pulmonary edema. This patient usually have obstructive sleep apnea and right-sided failure.
There is another question from Dr.
Talha. I had 1 or 2 slides about fluids, but I forgot to put it.
Okay, no problem.
Next time.
What is the ideal post-operative pain management protocol for the morbid obese patients?
There is no universal protocol, but if you have an ultrasound and you have someone expert and can give regional blocks, it's very good. PCA is actually it's said that PCA you will give narcotics, and this is very dangerous in the morbidly obese patient. So it's preferred to use the regional techniques and multimodal analgesia, as paracetamol intravenous, such as perfalgan, and non-steroidal anti-inflammatories, local anesthesia in the incision. Sometimes the surgeon can do that. And if he has severe pain, you can titrate, and it's written in the guidelines in the UK guidelines. If you don't know this specific drug, you don't remember, do we give it on the according to the ideal body weight or lean body mass or total body weight? So titrate and give slowly according to response. So the multimodal anesthesia will decrease, will not prevent the opioid. We may need opioid, but it will decrease the amount of the opioid.
The need of opioid, yes. Dr. Ahmed Shalabi asked about the drug dosages. How can we calculate the body weight? How can we adjust the drug dosages to such patients?
As I said in this slide, there is a table. You can have this table with you, and it gives you all drugs and each drug according to total body weight or lean body mass, and you know the equation. But this is a little bit complex. So it's recommended that you titrate and give in small doses if you don't remember.
Dr. Hani asked about what the best way for induction morbid obese. This is answered before. Use awake fiber optic intubation. صح?
Yeah.
We proceed is high body mass index above a certain value, an indication for ICU admission post-operative?
That's a good question. The post-operative, as we said, our aim is to extubate the patient fully awake in the sitting position, and he can guard his own airway with no nausea and vomiting, no aspiration, no hypoxia, no obstruction. We put nasal airway, but it's sometimes if you have obese patient with having an ultra major abdominal procedure, and so the explanatory muscles will be affected, and will have severe pain and guarding, and will not be able to take his breath. If he's obese, that will be very difficult for him. So sometimes we take the decision of keep the patient intubated and go to the ICU, and until the patient is pain-free, the neuromuscular blockade is totally reversed, and he's awake, and you have the criteria of and the scores of discharge from the recovery room. If you don't have all the criteria of discharge from recovery room, so it's better to take the patient to the ICU, at least for monitoring overnight. It's better than taking the patient to the ward and then we don't know the complications.
Okay, sorry about Dr. Hani question. He asked if the patient refused the awake fiber optic intubation. How can we deal with it? How can we proceed with the induction of such obese patients?
It's according to the to your experience and according to the procedure. For example, if the patient refused awake fiber optic, and you have an option of giving epidural or thoracic epidural, combined spinal epidural, for a cesarean section, for example, or lower abdominal procedure, it's okay. You go to regional. Otherwise, you should consent the patient and tell him about all the complications that could happen if we put him to sleep. And if he accepts, we do the rapid sequence induction with cricoid pressure. And of course, we have all equipment with us.
Yeah, proceed with inhalational or intravenous induction. Crash induction will be intravenous induction. Okay?
It's recommended that intravenous induction is better to avoid aspiration.
Obstruction and respiration. Yes. Last question from Dr. Fuad Osman. How does the Sugammadex be calculated according to ideal body weight or a total body weight?
Sugammadex is calculated according to total body weight, but some authors used the dose according to the ideal body weight, so it was very small, and the patient was in deep neuromuscular blockade, and they recorded that it was successful. So the idea is not only the body weight of the patient, it's the degree of neuromuscular blockade. We don't, it's not recommended to give Sugammadex to a patient in a deep block.
Many thanks, Dr. Nesrine, for such a very interesting and difficult subject to make it easy. Many thanks.
Thank
Dr.
you.
Saad.